Next, I invite our own Dr. Arya for her session.
The topic is with amblyopia, child with a patch.
So good morning. Thanks to KSOS and Dr. Naina Madam for giving this opportunity. My topic is child with patch tips for amblyopia management. So before going into the management of amblyopia, as we all know, it's a unilateral or bilateral reduction of the visual acuity, and it is caused by abnormal binocular interaction during the critical period, which is very important. And while taking history, what all things you should rule out? Always ask for prematurity, because history of ROP significantly increases the risk of amblyopia. Whether there is any family history, developmental delay, and ocular history like previous trauma, ptosis, or patching history provides a context. Now, what are the clues which help us to decide whether the child is having amblyopia? Whether there is any fixation preference for the child, whether there is any tilting of head, rubbing of eyes, abnormally increased blink rate, resistance to occlusion of the sound eye, closure of one eye in sunlight, examination of objects close to eye, and presence of amblyogenic factors. So, starting from the history, we already identified the risk factors. Check the visual acuity according to the age-matched assessment. Refraction, cycloplegic refraction is mandatory, very, very important. And check for strabismus and rule out any organic pathology. So, always do a detailed anterior segment and fundus examination. Now, when to order these investigations? As we all know, standard amblyopia is always a clinical diagnosis, and advanced imaging is reserved for atypical cases or when the treatment fails. OCT is essential to rule out subclinical foveal hypoplasia or any subtle macular edema, and VEP provides objective estimation of visual acuity or pathway integrity. It's useful in non-verbal children or suspected malingering. And neuroimaging MRI only for optic nerve signs, that is pallor, or any neurological deficits are present. So coming to the therapeutic ladder, you check the refraction, spectacle correction. Then you give the occlusion, that is patching the sound eye, which is still the gold standard treatment of amblyopia. Penalization using atropine or Bancarter filters can be given. And finally, the newer binocular therapy. The step one is refractive correction. And first you find out the refractive error of the child and give the full spectacle correction, and allow a 16 to 18 weeks for visual acuity to stabilize with glasses alone before starting your patching, because most of the amblyopia, according to the PREDICT study, gets corrected with your spectacle correction. And step 2 is the occlusion therapy, and by blocking the visual input to the sound eye or the dominant eye, the brain is forced to process signals from the amblyopic eye. This is a mechanism of occlusion, as we all know, and it overcomes the suppression and stimulates the cortical development. It has a high success rate in compliant patients, and the challenge is always a compliance and social stigma. Now, what are the types of occlusion patches that you can give your child? You can give the adhesive patch. It provides the best occlusion because there will be no peaking and it stays in place. But the problem is that there can be skin irritation or allergy to the patch. You can give cloth over the glasses. It is comfortable, but it is easy to peek around also. And pirate patch, it will be fun to play for smaller children, but it's not recommended due to the high risk of peaking and poor seal. Now, how is the patching dosage guidelines? For moderate amblyopia, that is visual acuity 2040 to 2080, 2 hours per day plus 1 hour of near activity is actually prescribed. The outcome is similar to 6 hours patching. And in severe amblyopia, we prescribe 6 hours per day. And what are the key strategies to maximize the compliance? It is easy when you start occlusion in a smaller child, because it is easier to establish the routine in younger children. And you can give some reward systems like sticker charts or special playtime during patching, the engaging activities, and family education is very, very important. Emphasize the neuroplasticity window both to the mother as well as the father. And when do you say that patching is a failure for the child? When there is no visual improvement after 3 to 6 months of compliant patching, no improvement even after at least 3 intervals of full-time occlusion therapy, it's recommended to always taper the patching with part-time occlusion of the normal eye 3 to 4 hours per day, or alternately patching both eyes. And when to stop occlusion? When the visual acuity in both eyes becomes equal, or the fixation becomes fully alternating, or when there is no further improvement despite 3 to 6 months of patching. And recurrence is always a problem in this patching. And when the acuity recurs again, still a slower tapering is advised. You don't, when you see 6/6 vision, you don't say to the parents that, okay, now you can stop the occlusion. You have to continue it for a little more period, taper, and then only stop. Second one is pharmacological penalization, atropine 1%. Atropine drops in the sound eye, paralyzes the accommodation, that is cycloplegia, and blurs the near vision. And it forces the child to switch fixation to the amblyopic eye for near task. Indications moderate amblyopia. Also, when the child is not compliant to the patch, you are not getting a good result with your occlusion alone. And various studies was conducted by PEDIC, and the study result is that weekend atropine provides similar visual acuity improvement to daily atropine for moderate amblyopia. The side effects are light sensitivity, conjunctival irritation. Now, according to the study, for moderate amblyopia, both modalities are equally effective, that is patching for 2 hours or weekend atropine. Both have produced 3 lines improvement. Next is a Bangetter filter. This mechanism is again the same. You can put translucent foils or apply to the spectacle lens of the sound eye. It induces controlled image degradation and reduces the contrast sensitivity of the sound eye, encouraging the amblyopic eye to see. The advantages are that it allows some peripheral fusion, and cosmesis it is less noticeable than a patch, and it's excellent for tapering treatment. Now we are shifting towards binocular therapy, that's a dichoptic therapy, rather than patching one eye. And the traditional patching is, as you know, it is monocular and it doesn't directly address the suppression. So goal is that you unmask the amblyopic eye and retrain the brain for binocular fusion. Most of the hospitals in Kerala are also using this Binox. The Binox utilizes modern gaming interfaces to deliver the dichoptic therapy. It's an interactive video games engaging for the children, and it's a real-time adjustment of contrast balance. It monitors compliance remotely. And there is significant visual improvement according to the Lockmar visual acuity chart. It is often seen faster than with passive occlusion alone. And the unique benefit is that improvement in stereo acuity depth perception by restoring the binocular cortical cells, which you don't get in a patching. And compliance gamification leads to higher adherence rates compared to the patching. Compliance will be better. Another one is the orthoptic magnocellular stimulator, as we all know, Dr. Sandana Gopal sir, and it has consists of 3 rows of light emitting diodes. And it the first step also helps to improve your hand-eye coordination when you point at the light that switches on using a laser pointer. And so diagnose and refract, full cycloplegic refraction, always mandatory. Give the glasses, allow a period of 16 weeks. No improvement, you go to patching, 2 to 6 hours, weekend atropine, and you can reassess after 8 to 12 weeks. Then you go to your advanced therapy, that is a dichoptic therapy for binocularity. Then once a child attains a vision, you can taper slowly to prevent the recurrence. So this is in a nutshell what I have already told. And so conclusion, again, occlusion and atropine remains the effective first-line treatments. And treatment should be personalized based on age, severity, and compliance. And early detection, that is less than 7 years, is the strongest predictor of treatment success. And always visualize the fundus to roll out organic pathology, investigate thoroughly, and treat aggressively. Thank you.
Thank you, Arya. You have made amblyopia more simple and easily manageable. But as you know, amblyopia is a very long journey.